SAGES Stories.
Welcome to today's episode of SAGES Stories, the official podcast of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Please make sure to hit the like button and subscribe so you can stay up to date with our most recent episode, and enjoy the show.
Okay,
Yeah,
here we go with episode 4 of SAGES Stories, where we shine the light on some of SAGES' most impactful leaders. I'm your co-host, Dr. Kevin El Hayek, coming to you from sunny California.
That's right. But that's
right.
that's my hood.
That's your hood.
But you're from Cleveland.
That's right.
And yet you're in California.
I am in California today.
I think everyone ends up in California.
You invited me last time.
Yes.
It was starting to get a little cold in Cleveland, so I came out for this very special SAGES Stories.
So this is going to be one of our most special SAGES stories. First of all, and least of all, it's because I'm in presence of Kevin El Hayek, my co-host. But most of all, because we are here at the home and residence of our dear, iconic Dr. George Berci.
good morning.
There we go.
We're so happy to be here with you today. Thank you.
Very nice.
Thank you for spending the morning with us here.
So those of you that are SAGES members all know Dr. Berci. He is one of our leaders, one of the original founders, and the most notable of SAGES members. I'm very lucky to have him in Los Angeles. I get to see him at my hospital very early mornings because you're there. What time do you get to the hospital?
Well, I'm getting there at 7 o'clock in the morning.
Why so late?
Sometimes 6:30,
I've seen you before 6 a.m.
Yeah, it's happened.
Yes,
6 a.m. is when I took my dog out.
this is right.
So, SAGES Stories is a relatively new podcast, and it is our goal to highlight unique stories of our guests. And at 101 and a half years young, there's no doubt that you will have a few stories to share with us. And I imagine looking back at these archives in a few years, we will remember episode 4 as one of the most fascinating to us. Many of our listeners will also know that there is a great book about your life so far, which is free to members who support the SAGES Foundation, and we'll put a link to that in the show notes. And certainly I recommend everyone to read that book. It is just a great summary of what you've done so far. We always like to start with just hearing a little bit about our guests, a little bit about your background, where you grew up, and just a little intro to your early years.
As you know, I'm afraid I'm a very mature person today, being 100 years old. But I had a very difficult background. As you know, I was born in Hungary, and spent 15 years in Vienna, came back to Hungary, was caught in 1942, a labor camp. My family, from 14 members, there are 2 survivors. Then went through the revolution part, and in 1956 I was able to, with my family, to escape to Australia. You could imagine I arrived there no language knowledge, but I received fortunately a Rockefeller Award in Vienna. This helped me, and I started to introduce endoscopic surgery. It was very primitive. And I, practically speaking, gave it up because the results were very poor. I was extremely lucky that I went to a lecture to London, and I somehow became informed with a physicist called Hopkins, who invented the new light system and the new optical system. The optical system was crucial because it's smaller in size and developed a magnificent image. Endoscopy is looking, and endoscopy is seeing something in a more detailed, more enlarged way. I was knowledgeable a little bit approximately about endoscopy, and I developed the first miniature TV camera in 1962 in Australia. And hooking up to the Hopkins system, we created an increasingly improved image. This was one of the major issues that this was accepted, produced now by several companies, that today laparoscopic surgery is so well accepted. The area was the States. Laparoscopic surgery was done. I wrote a book earlier, again, it was not accepted, but in 1989, it became a very important aspect for the patients because there was less pain, shorter hospitalization, and faster return to work. These three important aspects in surgery were created a demanding patient's procedure. And here we are with many thousand surgeons in 1989 who were non-informed, not trained for this procedure, demanded that their surgery should be performed in an easier, better way. Society of American GI endoscopic surgery are well known by a colleague, Marx, who established in the late 80s about flexible endoscopy, upper GI, called gastroscopy, or the lower colonoscopy. This is also something to do with the Hopkins system because his certain part of optics, the flexible optics, was also reported by Hopkins and changed here the world. Here we are in 1989, where thousands of surgeons are requested to be taught. SAGES immediately noticed this important aspect and started to first with a training the trainer courses every weekend in every other citizens in the States. We held courses with a maximum acceptance of 10 colleagues and started to train laparoscopic surgery on pigs. Of course, we also trained trainers, and in the first 2 years, SAGES was a dominant factor that today thousands surgeons performing laparoscopic surgery in the United States. The first area was the biliary system. We have today 1 million gallbladder removal or cholecystectomies per year. It's a tremendous number where 10 or 12, 20,000, 10 or 20,000 surgeons performing here. But it's immediately spread further. The other large area or the immense area was urology because prostate-megaly or enlarged prostate is a huge area. Millions of male in many countries have problems and need open surgery, and a large number of these cases can be performed today laparoscopically or through the cystoscope. Therefore, this was another area where we immediately changed surgery to better patient's care with less hospitalization and faster return to work.
So when did you end up working your way to the United States? So you were in Australia, and then the UK?
I became invited from Cedars-Sinai Medical Center in 1975. Dr. Morgenstern was the director of surgery.
Yes.
In the beginning, he didn't believe that we can do something, but he gave me a chance, and therefore we started the first cases here in '89. Great help was Ed Phillips, and of course, every surgeon demanded to be trained. Therefore, at Cedars, we did it approximately every day that we trained surgeons. And this is where the important changes occur.
So I'm curious, as a surgeon, how did you get interested in optics? How did you go from being a physician to doing something very kind of engineering, physics-based?
Well, I had previously 3 years of mechanical engineering before, which helped me significantly in later design. But the vision was obvious for me. In 1960, I started to do endoscopy, and looking through a small monocular eyepiece where you see only a restricted area, where you have difficulty see in the illumination, and you can't teach, you cannot record. Recording is crucial. This gave me the idea when I saw later on the Hopkins system that we changed the entire technique and results.
Yes.
Yeah. And how did you get involved with the company at that time? So this was an industry, eventually it moved to industry from the concept.
Well, when I saw the prototype in 1959, of course, I'm not a mechanical company or producing systems. I looked around, but unfortunately, none of the largest companies who became known from this one became interested. And I found a little German company who was interested in developing prototypes.
What year was that?
Well,
60s?
60s,
60s.
early 60s.
And what did you know Carl Storz before that time?
Yes,
Yes.
I know him. I was interested in certain bronchoscopes where he had some ideas. Therefore, I had no other possibilities after find out that ACMI, the French group, was not interested. And I met him that time. Carl Storz was a little company in a small city, Tuttlingen in Germany, with 25 workers. Today they have 5,000.
Wow.
Well, it is a great step forward because amongst surgery, the chest, in other words, thoracoscopic surgery, was an enormous big area. Again, I want to emphasize, of course, cystoscopy and urology was number one. But there was another area which we found later on important. This is anesthesia. The intubation in 1941
optical intubation.
Was a step forward. There was a little light on the curved laryngoscope.
Yeah.
And as soon as we put this in, you could imagine, you see the enlarged, this changed anesthesiology.
And were you doing all this as a crusader, as a maverick, being the first? Or was there someone, either a mentor or a professor or someone that you could seek guidance from or who helped you through the process?
Well, I had already, when we introduced it from urology, general surgery, we had responses. The most important was the patients were very impressed and demanding.
Yeah.
All right? Therefore, this was a great help. And if you could imagine, for the first 2 years, being at weekends in several other cities, and you get immediately the response back that you see that here we have something which is internationally interesting, but most important, it is a new surgical procedure which will change the outcome of surgery. And this is where we are today.
I mean, you mentioned that, and I know from reading that it wasn't easy, and there was a lot of resistance from the traditional surgical field. How did you handle that? And what was that like to go through that type of struggle with your peers and colleagues and senior surgeons in many
Well, I'll be
respects?
honest, it's $100 question. But it was extremely difficult because I myself have a couple of years behind me, but you're talking to guys, for instance, who did cholecystectomy for decades.
Mhm.
And how can you tell them that, listen, I do this, I have very good results. Our ductal injuries is small, which is not the area where we need still improvements. It was the major issue was the patient. Patient demanded, and there's no question, a patient went back home after a gallbladder surgery next day. Today, many patients going in come out from the hospital on the same day. Therefore, these are factors. Not speaking in urology, where somebody goes in and is a certain group where they can do a prostatectomy. All right?
Did the hospitals want you to bring these in, or did they say, no, this is not standard of care, we won't allow you to do laparoscopic surgery?
I have to tell you, it was like a revolution. I mean, because in every larger city in the first couple of years, some hospitals already introduced it, some hospitals already published, the newspapers were full. Therefore, this was a dominant factor that in certain areas of the city, they're doing it already better, faster, etc.
And that was in the private sector more than the academic, from what?
Well, academic was, I speaking only from LA. I was member of the academic department here. It was slow. But even there, after a year, people became convinced that that's the future, the technique, the future surgery. And it really changed around. And there are a lot of problems still today which need improvement. I'm working on certain areas where we definitely need further improvement to introduce a technique which is better than the others. But there's no question that endoscopic surgery changed surgery.
Yeah.
No doubt. And at that time, SAGES starts 83. Talk a little bit about your involvement in that and how this came to be, this society.
Well, I was introduced by Marx, that time with a couple of hundred surgeons involved, who claimed that they do colorectal surgery. And the very important pre-surgery colonoscopy or gastroscopy was done by GI guys. Therefore, they started to do it. There was enormous resistance amongst the GI guy to accept the surgery. And yes, we put here, SAGES was the number 2 in 1975, where we introduced colonoscopy as for surgeons. Interestingly enough, surgeons were not very much interested, because the other side of the story, which is very well known, is what is the reimbursement? And people came to me, surgeons told me, said, have a look, I'm doing a hernia in local for an hour or within an hour, and I get this amount of dollars. And this takes me a little bit of time, colonoscopy too, and I got only the half. But this was a very important aspect But later on, of course, it changed. And SAGES, that time we are 600, today there is 7,000.
Right.
And how
7,000.
busy were you clinically at that time? Were you a general surgeon that was very
I
clinically busy?
did general surgery. I taught, as you mentioned, I came relatively early in the hospital,
Yes.
teaching residents, but the correspondence and I did a significant amount of research work.
Mhm.
And CEDAS was very well organized for this. We had the facilities there. I got the people there. Therefore, the endoscopic instruments 5 years later were not the same, right?
Mhm.
I have forgotten to mention another area was, of course, gynecology,
Correct.
which was a tremendous large area, right? To do a surgery, a GYN surgery, laparoscopically instead of opening up.
So you were busy clinically, you were teaching, you were also doing research. That's clearly what we call the triple threat. How did you balance the research side, and how did you decide what to take on, what projects were worthwhile? How would you counsel someone who's trying to do research now with busy clinical, busy teaching?
Well, I had 2 days in the week where we went to the research lab and spent on new projects.
And
I
not
saw
Saturday
this,
and Sunday, right?
Saturday and Sunday, I wrote the paper.
You wrote the papers on Saturday. So that's the trick, right?
Yeah, I had problems with my children because I did also night sessions.
You took
On
call
the
as
weekend.
well?
Yeah, sure.
Oh, yeah.
On the weekend I slept,
Yeah.
It was a very difficult life. And summarized, I'm very happy that I did it. And looking back, there is a book which is it. The book is about 2 topics. One, I found 40 years ago a German surgeon who published cholecystectomy at the turn of the century. He published 2,000 cases. It was printed.
2000.
2,000. His name is Care.
Okay.
And people were not interested, perhaps they were uncomfortable that they didn't have so many cases. But this guy produced a book, 500 pages, where number one, 100 years ago, he mentioned that we have to train young surgeons and train them also in anesthesia. That time, people haven't a clue. 100 years ago. Right? Then he described how to do surgery, how to take a history. What impressed me when I got the book, and I, of course, was very busy, that's why I read only a few pages at the time, is that he had an artist. He built a podium behind him. The artist took him 5 or 8 months to learn the anatomy. He made color drawings in 3D about surgery. And nobody noticed. Therefore, I took this book of 490 pages and the last 3 years, and I translated it to 60 pages.
Good, for the rest of us.
As mega summary.
For the rest of us, yes.
And then I took the color pictures, because if you have a look, you can see what difficulty. But I had a very good technician whom we redid it, the printing, that you get the 3D effect. But could you imagine 100 years ago, he was interested to have color records of a he had large number.
Yeah, K-E-R-R, right?
K-E-H-R.
Care.
Now this guy did something. Into that time, of course, the majority of patients were jaundiced. I ran around with the gallbladder for years. Now, this guy found out that there's a large number of incidents of CBD stones. It's another subject for today, where we still have to improve our situation. And what he did, he found, I don't know what it was, a very malleable little tiny probe. Wherever he incised the cystic duct, he put it in, and if he found resistance, I opened up and found the stone.
Oh, wow.
After this was the early idea about cholecystectomy.
So I'm curious what your take is as a inventor and promoter of new technology. We're getting to a point where residents are getting very good at laparoscopic surgery for gallbladder surgery, hernias, most things, appendicitis, but they've lost their ability to perform open surgery. So what's your take on that? Are you okay seeing that transition, or do you feel that we need to start teaching open more
The
now?
summary of my way of thinking after 33 years of introducing it is that we did a tremendous work in starting to learn new technique and using it properly, but we don't have a proper recording system. This is number one. Number two, we didn't spend enough time with the residents.
You mean in open or
for
in
open surgery?
Yeah.
Okay.
Yeah.
All right.
This is one great area where the
Mhm.
various associations, ACS and SAGES, in future have to achieve some changes in the training.
Yeah.
Yes.
The other one, you could
Good
imagine, when I mentioned before, we had 1 million cholecystectomies laparoscopically. Out of this, 10% have CVD stones.
Yes.
This is 100,000 patients. The majority of surgeons are not trained how to do operative imaging, a cholangioscopy.
Yeah.
They are not trained how to use a choledoscope. And today, 100,000 surgeons must have patients must have a ERC.
So Kevin
So
flew
yeah,
in.
Yeah,
He told the story.
I wanted to talk to you a little bit about that. You know,
Go ahead.
What is the so first the surgeon's role in the bile duct? A few years ago, you reached out to me through Jeff Ponsky to talk a little bit about the move to high definition cholecystectomy, because before the image wasn't very great, and since then there have been a number of new devices that have emerged. And you actually inspired me to really, what I would say, take back the bile duct in many respects as a surgeon. And I do routine cholangiogram, and it's always brought up in my cases. And actually, last night I had one of these cases where I did a cholangiogram and I saw bile duct filled with stones, and I had to set up to do the bile duct exploration. We did it. Patient went home this morning. So what is the role of the surgeon in the bile duct, and how should this be treated in the future?
Well, you can't change the present political situation. Because I think there are so much politics involved that you have here, I don't know how many thousand surgeons who are doing it, but have no idea who do an operative cholangiogram.
Yeah.
Who have no idea to use a choledoscope.
Yeah.
You can't get them out for a training.
Mhm.
There is only one solution, that 5% of these 100,000 patients have pancreatitis.
Yes.
Yeah.
5%.
Yes.
Then-
And a stent. They all get a stent. And they
yeah,
all get a second procedure to get the stent out.
yeah.
Right? So it's 3 procedures.
There's a
there are-
mortality associated with ERCP.
There is
Yeah.
only one solution, that the two large societies, the American College of Surgeons and SAGES, have this data. There's nothing new what I'm telling here. Everybody knows it. It's in print. There are 2020 Annals of Surgery editorial. It's printed. But you have 200 surgical residency program in this country.
Mhm.
200. Every resident in 5 years performs 100 cholecystectomies.
Mhm.
He has the knowledge. To introduce to these residents on the 4th year intraoperative imaging in choledoscopy, It's not a problem.
Right.
And then you're creating a better trained biliary surgeon, and you're saving. There's no question that the bile duct injury, which is a catastrophe,
Right.
is higher. We don't have proper numbers.
Right.
This is
So it
my
has-
answer to your
It
question.
has to be a pipeline. Has to start with the residents then and the
Yeah,
trainers.
yeah, you can't change that, right?
Right.
But therefore, I did
So that's
want
where
to
I
give
should
an
focus.
analogy with today politics, but
Yes.
you can't change it.
You're right. No, you're right.
So as part of SAGES, were you among the handful of surgeons that got together saying it's important to develop such a society?
There is no question that when we came to the stage of laparoscopy,
Mhm.
then I got a large number of SAGES members who were interested, help trained people. In other words, there was a big step forward called training the trainers
Train the trainers. Yeah.
by SAGES. Today, marvelous 7,000 people.
But before SAGES became a bona fide society,
Yeah.
did a bunch of you sit around at someone's dinner table and say we should make our own society, or how did that?
Now, this was triggered by a French surgeon, the changes at SAGES. I was only one voice there,
Mhm,
a couple of voices, called Perisson,
mhm.
who brought to the SAGES meeting a video.
Uh,
And this was far before I was 88. And we were able to show it to the committees and to convince them that we have to do something. This was a turning point. It was a great help.
So you went on to become the 11th president of SAGES in 1993. How was the society viewed by other major societies at the time, places like ACS and some of the SSAT, for example, some of the older societies? What was, when you became president, what were some of the, environments like with these other societies?
Sorry, it came to my idea that if I would compare with today's situation,
Sure, go ahead, yeah.
you can't, you have two parties and they couldn't come to a common denominator. Right here is my answer.
Yes.
But it was a very slow process. And again, it was very remarkable that other disciplines like thoracic surgery, GY, and urology took over, where they don't have the problem, as far as I know, that we're leaving 100,000 people to have an ERCP.
You're right, I think you're right.
It's different there. But surgical societies have to wake up and see whether the figures that we are quoting are correct and do something. Again, you cannot change the situation. There, it's only one hope that the surgical residency programs will be improved.
So you very briefly talked about your family. We all know Barbara, but we don't know much about your children. I've had the pleasure of meeting some of your children and grandchildren at many of the award ceremonies that have honored you locally in Los Angeles. But maybe you can tell us a little bit about your family and also how they dealt with all of the work you were doing. You were so busy and traveling and inventing. How were you able to, also play the role of a father and husband and balance all of that?
This is a very difficult question because no question that they suffer. As I mentioned briefly, I slept a lot on the weekends. In the early stage, I was not very much involved in the kids. It was interesting that the kids started early tuitions in schools in Australia.
Mhm.
the British
Oh.
system,
Okay.
and it's completely different.
Okay.
I didn't understood there. Everybody had a uniform. Everybody was the same, right? There were no jeans with a hole on the knee side
Yes.
and so forth. But they were here very well accepted. They know quite a bit. Therefore, the system, teaching system in the British system, what I can was better. Back again, I was able to help my son, who became an engineer, who was a famous skier, and he became immediately the team captain from UCLA.
Oh.
But on the weekend, they went training. When he came back on Saturday, they slept on Monday in the school, UCLA. He became a dean's dismissal. And therefore, I started to become involved, and I helped him to get his degree somewhere else. But there aspect, there is no question that I had less time to involved in the education of my kids. One of my kids, unfortunately, died who went back to Australia.
Sorry.
But my son Vincent and my daughter Kitty, they are here. Of course, they are mature, family. But to answer the question, now, if you have only 24 hours and you spend 14 hours on a certain project, it's difficult. But that's, I'm very happy that they are okay.
How many SAGES meetings have you attended?
Many.
How many have you
Was
not
it too many?
attended?
Yeah.
Have you ever missed a meeting?
Recently I'm missing, but no. We had so many interesting problems to solve on a yearly basis.
Yeah.
You know, we had so many interesting ideas came from outside that it was I think laparoscopic surgery would be nowhere without SAGES.
Oh, I agree.
Oh, for sure.
Because you have 6,000 people, surgeons today.
Yeah.
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 So this final segment is one of our most fun segments. We feel that we all love SAGES as a society, but the meeting itself is kind of very unique among most meetings. So we call this the We Are the SAGES segment.
Oh yeah, this is our singing notes on the
Yes.
on the very last end. We have fun.
We are the world. We are the SAGES. We are the SAGES. Sing it, everybody. We are the ones who make it bright our day. So let's start treating.
We do have fun, just like this podcast. At the very last end, we
Yeah.
have fun. So I remember multiple times during the We Are the SAGES final gala, the sing along. I've seen you wear multiple different costumes. You have performed up. You performed up there. My favorite was when you wore the Indian chief long headgear that dragged to the floor. That was.
I'm sorry.
That
I was told to do it.
Yes, and you did. So maybe you can take this time to share some stories that we don't know about, something fun, interesting, unique, memorable about the actual meetings in the past.
Well, it was very important to me who was member in other countries of societies. It was really the British one. You know? You have there the various castes.
Yes.
Yeah.
And compared with this, it was for me a great fun. I was proud. I have to admit, despite my comments, that I was the first, I call it bloody foreigner, who get a department title, so they were very nice to me. Therefore, I can't,
You can't pick one.
no, I can't pick one. Here, I mean, we had fun. I hardly can remember because the majority, what I get topics were problems to solve.
Yes.
And on the weekend, then was it Jeff Ponsky, was Boston, and so forth. They came with problems, they can't solve it. Therefore, I found out how we can solve it politically, professionally. I had many, many friends and colleagues, and it was nice. I mean, Green did a super job.
Yes, he's great.
Yeah, who was editor of the surgical journal for odd years, but it brought us together. Despite the fact that I don't remember what I sang or what I did as a Indian sheriff or whatever
Yes.
I was, is that you get closer
Yeah,
as other society meetings.
very
Yeah.
much. Very much.
This is what SAGES did. If I compared with other surgical society meeting, it was not stiff.
Yes.
It was right down to the job.
So, any last words of advice for a surgeon out there who's listening who wants to leave an impactful legacy through their surgical career?
Well, if it's in the biliary area, then he should consider to learn about the CBD stones, which is 10%. We don't have figures, but there is a very important aspect. The bile duct injury has a tremendous high mortality. It's interesting, I published a lot. We had a mortality of 0.3% for open surgery. In the first 2 years, it went skyrocketing. Today, we don't have proper records. Therefore, there is one for the surgeons who are in a position who can afford time-wise to learn a little bit, learn these two aspects, and complete the biliary surgery in one surgical procedure, what we did before. This would be the greatest contribution to patients' care.
Well, that was wonderful. I just want to really thank you for your time.
Yep.
It's a Friday morning. You've gifted us with your time, Kevin, all the way from Cleveland to take this momentous moment with you. And I'm very privileged to have you locally. So I hope to see you around the hospital again.
You will?
You're always at M&M and Grand Rounds
Still.
before everyone else.
And that wraps up today's episode of SAGES Stories. You can view the show notes for additional information mentioned on the show. Also, please visit sages.org for membership information and for the most recent news from our society. Follow us on Twitter at @sages_updates. Make sure you hit the like button and subscribe so you don't miss any new episodes. Tune in again next time, and remember, you can't spell minimally invasive surgery without SAGES.